we're good to go.
I'd say good to go now, David. Still not quite quiet, but enough to make a start.
Great. Okay, so welcome everybody to the first meeting of the ICB for 2025, and a belated Happy New Year. Is it still appropriate to wish people a Happy New Year at the 16th of January? Anyway, belatedly a Happy New Year. Just in terms of a few housekeeping rules for this afternoon's meeting, if I could run through those first. Staffordshire and Stoke-on-Trent Integrated Care Board meetings are meetings in public, not public meetings. The meeting is being recorded and will be available on the Integrated Care Board website after the meeting. I'd ask if all cameras could be off except for the chair and those presenting items on the agenda when we get into the meeting. And if you could make sure your microphone is on mute, we'll hopefully get much better sound quality as we move through the process of our proceedings this afternoon. Any questions that have been submitted in advance of the meeting, we will deal with at the beginning of the meeting, and there will be an additional opportunity to ask questions at the end, and we'll take those then. Paul, I can see you've got your hand up, so if you'd like to come in before we just go into apologies.
Yep, sure. You're now fully quiet, David.
Thank you, Paul. So in terms of apologies for this afternoon, and I'll come back to this in a moment, we've got Pat Flaherty, Heather Johnson, Lynn Tolley, Megan Nurse, Simon Constable, Helen Ashley, and we have Showcat joining us late. And I just want to go back and also just raise that Tracy Shewan will not be with us this afternoon. She has a family funeral, and Claire Cotton and Paul Winter will be covering off the items for Tracy on the agenda this afternoon. Just in terms of the apologies, everybody on the call this afternoon will be aware of the pressure that colleagues are facing out there managing the winter pressures across Staffordshire and Stoke-on-Trent. Can somebody, Anna, would you mind just putting your microphone off? Thank you. Colleagues obviously have a first and foremost priority of actually dealing with those pressures. So many colleagues this afternoon have had to make sure that they are attending to the frontline operations and work to protect our patients. And that's why the board is slightly depleted for today. If we could just go into enclosure 1, item 2, the leadership compact. This is on all of the meeting schedules for the ICB and the ICS, and it's an important document that guides the way that we conduct ourselves and conduct our business as we operate as a board. I'll just check under enclosure 2 if there are any conflicts of interest that anybody would like to raise on this afternoon's agenda. Paul, you've had nothing advanced. Thank you. If not, we will note that and move to item 4, enclosure 3, the minutes of the meeting that we held on the 19th of December 2024. And if we could go through those now for accuracy first, and then we'll come to the matters arising and the action log. So in terms of the minutes, page 1, page 2, page 3, page 4, page 5, page 6, page 7, page 8, page 9, and page 10. If everybody is happy with those minutes, we will endorse those. Moving into item 5, enclosure 4, the action log. We have a number of actions there, Paul and Phil, that we need to pick up. I'll just get those up if I can. Just bear with me on the screen. So the first one was a question from Megan regarding urgent and emergency care. Phil, are you able to give an update on that, yes, which is item 8 on the action log?
Yeah, thank you, David. So I'll pick up more detail in my update on the agenda, But to directly answer the question that was there, which was around activity levels, so while November attendances across all types of UEC attendance were 5% below those observed in October, this is a normal seasonal move that we see. The important part, which I'll pick up later on, is that November 24 attendances still represented a near 8% increase on the year before. So although the month-to-month variation looks like a reduction when you compare year to year, it's actually quite a significant increase. Thanks.
Thank you very much, Phil. Phil, if we could just ensure that the outcome update on the template is completed through Lisa, and then we've got that for audit purposes,
Yes.
that we've just signed off that action. Item 9 is coming back to the board in March with a paper. Item 12, Paul, is Julie Holder's questions concerning the assurance report from the Senate.
It is. Thank you, David. Thank you for raising the question, Julie, and I'm really sorry I couldn't answer it on the day. I've spoken with the authors of the original paper that went to Health and Care Senate, and they've confirmed the original paper included the following statement, which confirms that schools were involved. So the statement in the paper said the toolkit has been developed through a collaboration of children's OT therapists at Combined and MPFT, educational psychologists and assistant educational psychologists at both Staffordshire and Stoke-on-Trent councils, and it has been shared with a small selected number of schools across Staffordshire and Stoke-on-Trent, and the feedback was positive. So I'm hoping that answers the question, Julie, that you raised.
Thank you, Paul.
Thank you.
Julie, that covers that off. Thank you.
Yeah, thank you.
Paul, again, if we could just add that narrative that you provided there very helpfully in response to Julie's question onto the template, and then we have the complete record. And finally, item 17, Phil, was Mr. Ian Symes' questions around ambulance conveyancing. Can you just give us the update on that as well, please?
Yeah, thank you. If it's okay, I'm going to pick up that detail as part of my overall winter update further down the agenda. I'll make sure it incorporates the points that Mr. Symes raised. Thanks.
Okay, thank you, Phil. And Phil, just again, without repeating myself, just if you could complete that section of the template as well, so we've got that in place. Okay, thank you, colleagues. So we'll just move into questions that have been submitted, Paul, in advance of the meeting. Would you mind just taking us through any questions that we've received?
I can, yes, David, thank you. They're both from Mr. Ian Syme, one of which continues on from the issue just discussed around urgent emergency care and ambulance handover delays. It is a lengthy question, so that has been forwarded on, Mr. Syme, to the relevant ICB leads. So if you don't mind, I'll read out a truncated version of the question now, just to get the salient points across for the record. So the question is, in today's CEO and Chair's report, agenda item 6, paragraph 4, points to a significant deterioration in timely ambulance handover delays in October of last year at Royal Stoke and County Hospitals, with the October situation being very significantly above plan. The winter surge plan of efficacy will also be reliant on ambulance handover delays being minimised and improved. I have previously queried the ICB about the protracted ambulance handover delay situation at Royal Stoke, and put several questions over the years to UH&M board, and of late to the West Midlands Ambulance Service Board, in terms of the now 45-minute maximum standard for ambulance handovers, reduced year-on-year conveyances in the WMAS report, but despite less ambulance conveyance to Royal Stoke, delays in excess of 60 minutes have substantially increased. Further, in the 6 months, April to September this year, the same metric is showing the same, and exceeding the 45-minute standard. There have been significant resources and public monies invested to improve UEC performance from an increasingly strained financial envelope. Whilst UEC performance is a whole system issue requiring whole system ownership to ensure improvement, as much remains within the remit of providers to assist service improvement. There's ambulance from chief officers' reviews that very busy emergency departments in tertiary acute hospitals have significantly swifter ambulance handovers than UH&M. What assurances have there been what assurances have there been given to the ICS ICB that the deterioration in ambulance handover delays at both EDs within UH&M will be minimised and dramatically improved, so that ambulances will be swiftly released to do their job of responding and attending to emergencies elsewhere in the community, instead of being stuck outside an ED waiting to offload their vulnerable patient?
Okay, thank you, Paul. And Ian, thank you for the question. Ian, I know you've got your hand up, and I'll just bring you in very briefly, if I can, at this stage in the meeting, just to clarify anything you want to around the question. But at this stage, Ian, obviously there'll be an opportunity at the end of the meeting. I'd just ask you if you wouldn't mind just being quite brief.
Yeah, sorry, Paul, that was last month's question. I've sent questions regarding dentistry and quality and safety to this month's board. There's been a bit of a mix-up here somehow.
Okay, Ian, thank you for clarifying that. Can we, Ian, what we'll do, we'll find those questions, unless Adele is going to bring those in now, we'll deal with them. Failing that, we'll find them during the course of the meeting and deal with them at the end, with the questions at the end, Ian. So you'll get the opportunity of asking the questions. Adele?
Thanks, Chair. I've got the question here. So in terms of the dentistry question, I put a question to the September 2024 ICB as to the state of play of the West Midland Dental Strategy. The ICB informed me that the West Midland Dental Strategy will be presented to the January 2025 ICB meeting. As the West Midlands Dental Strategy is not among the January papers, what is causing the delay in placing the strategy in the public domain? And when will that strategy be put before an ICB public meeting for debate and discussion?
Okay, thanks, Adele. And Adele, have you got the second question for Ian after Paul has responded to that? And Paul, I'm assuming you'll respond to that on
yes,
if
that's fine, David. So thank you, Ian, for the question. So absolutely, the West Midlands Dental Strategy has been drafted. All 5 of the ICBs in the West Midlands are working together and ourselves to finalise a local dental plan. Unfortunately, the original stated timeline, as you've highlighted, has been delayed for all of the West Midlands ICBs. And part of that reason is seeking absolute clarity on the amount of funding that's available for dentistry, both nationally and regionally, and when that funding or any additional funding might be released and available. I want you to be assured, however, that we are taking every opportunity we can in the meantime to tackle the issues that you know we face. For instance, work still taking place locally on redistributing dental activities being handed back by contractors. And we're doing that using the Dental Health Equity Audit as a guide, so we can ensure we're putting dental activity in the areas of the greatest need. I hope that the strategy and local plan can be brought to an ICB board for public debate by 31st of March 2025. Thank you, David.
Thank you, Paul, and thank you for the question, Ian. Adele, Ian's second question.
Yes, thank you. So the second question relates to the System Quality Group report. Reference is made of UH&M ED harm reviews, and that such had been agreed as now superseded by NHS England requests. Furthermore, it was identified that Queen's Burton have a different harm review process overseen by Derbyshire ICB. As this is clearly of concern to the Quality and Safety Committee, there's 3 parts to the question, Chair. Has the Queen Burton situation now been added to the risk register as requested? Clarification, please, as to why the harm review process, i.e. Queen's at Burton, necessitates that concern, and could a flavour of the NHS England requests that have superseded the initial UH&M ED harm reviews process be given, please? I do have answers if no one's on the call to give those, but
Okay, so Adele, if you are able to give an update to Ian on this, as I
Yeah.
said at the start of the meeting, we are missing key members of the nursing directorate today, who would, Heather or Lynn, would have given the report back. So what I suggest is if you could give an update, and then we will make obviously a more detailed update following the meeting.
I will do.
Okay.
So the answer to the first question, they can confirm that the action was completed and the risk does now sit on the risk register. Concern was raised with regards to the timeliness of the notification when harm had been identified within Queen's Hospital Burton Emergency Department, and Staffordshire and Stoke-on-Trent ICB received retrospective updates via the monthly contract quality review meetings. And then the third question, there is a template attached to give further context, and I can make sure those are forwarded on to Mr. Syme.
Thanks very much, Adele. Paul?
And just also to say thanks to Adele, and apologies to the board, yourself, David, and to Ian. I've been forwarded the wrong email with the wrong questions on. So.
No problem at all, Paul. We got there in the end. And Ian, apologies for the confusion there. And thanks for clarifying that. And hopefully that gives you assurance and responses to the questions that you've raised with us. And any further updates will be sent following the board meeting today. Okay, so if we can move on, that is all of the questions. Can I just check just the two from Ian that we'd received in advance? Yep. Okay, thank you. So we'll move straight into item 7, enclosure 5, the chair and chief executive update. I just want to be fairly brief with a few issues I want to pick up myself. Just in reverse order, under 7.1, I just wanted to alert the board to the new assurance committee for strategic commissioning and transformation, which has now been established, which will bring all of the traditional aspects of the commissioning cycle, etc., together. So a really important part of the revised governance for the organisation. Had the pleasure of chairing the inaugural meeting, which was very well and energetically attended by everybody who came from the local authorities and our statutory partners. There were some very helpful steers on the future terms of reference and membership, particularly around primary care, particularly around children and young people and the VCSE sector, which we're taking into account going forward. We're in the process of recruiting a non-executive member to the board, particularly with commercial experience, to take on the chairing of this committee in due course, and hopefully in the next month or so we'll be able to announce that we've been successful in securing that person. I just wanted also to make reference to the tremendous work that's been going on around vaccination across the piece, and to thank the community pharmacies, primary care and GP services for the splendid effort that they've been undertaking to make sure that people are vaccinated if they want to be vaccinated, and that is noted in the report. Peter, I'm sure, and Paul Brown in due course will pick up just in terms of the I&I and financial position and the response to the undertakings that we've got from NHSE. A lot of work ongoing there, and system work with all of our partners to try to get ourselves into the best position we can during this year, but obviously focusing on the planning for 25-26, which we know is going to be also a very challenging position. So Peter, that's all I wanted to pick out of the report. I'll just hand over to you for any exceptions you'd like to raise at this point.
Yeah, thank you, David, and good afternoon. Also, I was also going to mention the Strategic Transformation Committee, the establishment of that. So this is probably a fault of us not comparing notes beforehand, David. But I will just add that I think that's a vital part of our governance structure going forward, and particularly timely that we've introduced that in Q4, because of course traditionally the NHS during January, February and March are deeply immersed within the planning process to make sure that we get into the new financial year with clearly defined plans, both at that sort of medium-term strategic level, but also in your operational plan. So I expect that committee over this quarter to do a lot of heavy lifting with regards to defining the plans, both in terms of allocative efficiency, so where we'll distribute resources differently to improve outcomes, but also to an extent the technical efficiency and productivity agenda as well. So a really timely addition. Linked to that, I'd also like to mention the first point actually on the report, which is around community transformation, and one of our key 5 areas of focus stemming from the medium-term plan, very much obviously orientated around the left shift, bringing resource upstream. But hopefully colleagues that did attend that are on today would support the fact that we had a really productive workshop in December. The next one is imminent, where I think we hope to be able to clearly define our expectations for this coming year, particularly in relation to our core offer, our core community services offer going forward, and perhaps then from there the key areas of focus, particularly in terms of long-term conditions and frailty and that environment that very much at the moment is pressurising us in the UEC space. So some really important activities coming up. Hopefully I've described it in such a way that creates that relationship link and synergy across both governance and activity areas to make sure that we're in a fit place for 25-26. I'll stop there, David. Thank you.
Thanks, Peter. So just pause there in case any members of the board have got any points of clarification. Julie?
Thanks very much.
Julie,
sorry.
Just before you take the question, can I just ask everybody on the call, if your microphone is on, would you mind muting it, because it will have a detrimental impact on the sound quality of this afternoon's meeting. Thank you. Julie?
Thanks very much. Thanks, Peter. I was just picking up, well, a couple of things really. One was, or 2 questions and a comment, if I can. So in terms of that 25-26, we're into 25-26 planning now. And I just wondered, all the good work that's been happening about community transformation, whether we will be able to actually see that shift in resources as part of 25-26. That was my first question. The second question was around, given the incidence of flu, I guess less for you, Peter, but given the incidence of flu, which has really been requiring a lot of hospital admission, I just wonder if we've been collecting data to understand those people that have been hospitalised, if they'd been vaccinated, to understand whether there's any link there. That was my second one. And really just to pick up probably with Paul later on the finance report, is just really the reality of being able to get to the financial position that we are required to get to. It's more a comment than a question. Thanks.
Thank you, Julie. Peter?
Yeah, so I'll probably bring Paul Edmondson-Jones in for the flu item if he's happy to. Yeah, Paul will either be happy to in a moment pick up the money bit or in the finance section in the round. Just on the first item, and Elizabeth may or may not wish to come in on the back of what I say. So transformation in its sort of broader, purest sense does take time inevitably, because we're talking about moving resource, moving individuals, perhaps changing roles, etc., etc. Geography might be involved, so that inevitably takes time, if only because, of course, the contractual limitations that surround those kind of major change programs. However, not all transformation is at that scale. So what I hope and expect is for us during 25-26 to do a phased piece, which will, yes, acknowledge and deliver the big stuff that will happen at a point during that financial year, but to not then assume that everything needs to be put into that bucket. So where we've got the opportunity to make incremental smaller change and improvement, and I won't necessarily describe anything specific in that regard, others may have a view, but where we've got the opportunity to do that, let's take that opportunity rather than put everything into the big at-scale transformation box, whilst making sure that we retain the linkages between the smaller stuff and the larger at-scale stuff. So I suppose what I'm saying is I acknowledge the fact that major transformation does take time, but I'm sure that within that programme, there'll be quick wins that we can implement sooner rather than later.
Thanks, Peter.
And as I say, Paul, I think Paul popped onto camera and then off. Yeah, so there's Paul for the flu vaccination item.
Just to thank you for the question, Julie. I don't know the exact figure. I am 100% certain that the vaccination status is recorded for each patient that comes into the hospital. I don't know what that percentage is off the top of my head. I'll find out for you and let you know what the figure is. And if you want me to, I could just put something back to board next time.
Thanks, Paul. Thank you.
Thanks, Paul.
And
And
thanks,
Julie, on
Peter.
the last one, if Paul picks that up during the finance report, is that okay? So Paul will ask you to cover that off, if you will, at that point. Thanks. Julie, your hand's still up. I take it it's legacy, yeah? Yeah. Thank you. Okay, so we'll receive the report and be assured that the leadership are working on each of the topic that's been raised within it, and move on to item 8 if we can, which is the cyber security update, an important report coming to the board this afternoon. And Chris Ibel's going to take us through that. So Chris, can I hand over to you and enclosure 6, please?
Yeah, sure. Thank you very much, David, and good afternoon, everybody. And I really welcome this opportunity following the board development session we had around this as well. I want to start just by setting the context. And by the way, if you want to follow along in the slides, I'm not going to show them on the screen, but they're on page 27. But I want to just start by saying that back in September 2024, so relatively recently, there have been a number of changes that have been introduced to the DSPT, that's the Data Security and Protection Toolkit requirements. And you will start to hear this being referred to as the CAF-aligned DSPT, which is a cyber assessment framework. Now, why is this important? What does it mean? The cyber assessment framework aligned DSPT serves to strengthen our cybersecurity assurance for all government organisations, not just the NHS, but the NHS is part of that. So it includes the requirement for independent cyber audits, because before this has all been self-assessed, but now it includes formal independent audits of that, and also requires boards to be appraised of the risks and the mitigating actions we're taking regarding cyber. And I suppose the purpose of this update, this brief update, is really exactly that. It's to just provide that assurance that we've got the risk on our risk register, on our BAF, that we have the mitigating actions, and we know how to react in the event of a major incident. So just running through the slides, and I will take them as read, but I think I just want to highlight a few points. Lord Darcy's report was clear. One of the key focus areas was the analog to digital. And this sort of ties directly in with this, because what we've seen is over the last number of years, a definite increase in cyber attacks across public sector. And also this includes our third-party IT providers, so that supply chain. It's not a matter of if we will be attacked, it's simply when. So it's absolutely critical that we're well prepared. And, you know, we have an increased reliance on digital solutions, and it will only increase as a result of the analog to digital approach. So there have been a number of incidences, and I've highlighted them in the document: Arrow Park, Clatterbridge, Wirral, up in the northwest. That's recent as November. We also, a couple of years ago, if you recall, we had the Advanced incident, not only at Astra and Care Notes, but also it affected our own system when it came to financial systems access. And for those of you that have just read the HSJ updates this morning, the Synovus pathology cyber attack cost them £33 million. So significant financial and operational impacts as a consequence of these. And then, of course, there was CrowdStrike as well, which people will be aware of. Now, that's not a cyber incident, that's a system failure, but the fact remains we need to be prepared. So there's a significant national focus on this. The Department of Health and Care has created a cybersecurity strategy through to 2030. It's underpinned by 5 pillars, which I won't go into at this point. But it's what we need to take from that is the point I raised right at the beginning, which is the DSPT is being enhanced and changed and strengthened. And we also need to focus on our cyber resilience. So what do we do in the event of a major incident? And we've been working closely with our EPR colleagues on that. So digital, the framework in which we work, and you will have seen this when we talked about our digital strategy, we work within a framework called What Good Looks Like. And the 3 main pillars for that is digitize, connect, and transform. So when we've talked about our digital initiatives, that's the framework in which we operate. One of those areas is safe practice. And we have certain obligations as it relates to cyber and safe practice. And this is, I've outlined these, but we need a plan for maintaining cybersecurity. We need a process for managing the cyber risk and the mitigations. We need the roles that can fulfill that, so things like, or people and roles such as CSIRO and DPO. We need to make full advantage or take full advantage of the national cyber services that are provided by NHS England, and we need to comply with the DSPT and the new CAF-aligned DSPT. So what I want to do very briefly is just run through and provide some degree of assurance as to what we've been doing, not just recently and reactively, but what we've been doing over quite a lengthy period of time to put ourselves in a good position and invest in our cyber capabilities. So over the past 18 months or so, we've established a cross-ICS cybersecurity group. This is comprised of cyber expertise, not only from our NHS providers, but also our local authorities. We have actually worked up and we have a draft of our Staffordshire and Stoke-on-Trent cybersecurity strategy. That is mandated by NHS England, but we were working on that in any event, and that needs to be finalised by the end of this year. But we have a draft and we've submitted that for national or regional review. And we also have cyber, as I think most of us will be aware, on our BAF risk register. And we've got a number of sort of actions to mitigate that risk. So while we've established the cybersecurity group, which is a good thing, so we have some degree of a working group as well as a governance function, we've also defined the strategy, and most importantly, we've actually developed a security operations centre, which I've shared before, but we've continued to mature that offering. I think, and I speak under correction, we might be the only integrated care system up and down the country that has actually got a uniform, standardized security operations center, excuse me, operating 24/7, 365 days a year, that can actually proactively perform vulnerability scanning and patching across the board, including our local authorities. And I think this is testament to the great working and interworking that we have across both providers and also our local authorities. So they have standardized the reporting metrics that they report against. As I say, we do gap analyses to make sure we have continuous improvement, and it really enables effective knowledge sharing across our community. So I'm really pleased about that and the progress we've made with that. So in order to, just coming back to the point about preparation, we've actually run a cyber simulation event earlier last year, and we will be repeating that in coming months. And we've developed a 22-step action plan as a consequence and an output from that meeting, that simulation event. And that simulation event is not done sort of in splendid isolation, it's done with our regional and national colleagues as well, together not only with digital colleagues, but also with EPRR. So currently we're working through those actions. It's quite a long shopping list, but it's really to make sure that we have the right procedures in place, that as and when a significant cyber incident does occur within our area, then we understand how to manage that, It's basically the incident escalation processes that we need. Bear in mind that not all cyber incidents are sufficiently serious and warrant a system response. There are many phishing attacks which happen in individual trusts, which don't need to be escalated, but we need to be clear that when something impacts a critical system, we need to understand how that impacts us in advance and how we will respond to that. So in essence, we have a cyber strategy, we have a governance group, we have the Security Operations Center, we've got this on our BAF risk register, and we have this action plan that we're working through to ensure we understand our assets, the impact that these might have, but also what do we do in the event of a major incident. And David, I'll pause at that point and ask if there are any clarifying questions.
Chris, thank you so much for bringing that to life, actually. For a lot of people, this is quite a complex arena if you're not immersed in it. It's critically important. And actually, just looking at the recommendation this afternoon, it almost seems a bit inadequate to note the report and raise awareness when I think what you're delivering to us this afternoon is obviously a dynamic process of assurance to the board that we are trying to keep ahead of the curve in an environment that presumably is moving all the time and the threats are moving all the time that you've got to keep us safe from. So thank you for that. We'll take a number of questions that have come forward. Claire, welcome. Claire, I think you might be on mute.
I am. Sorry about that. Thank you. And just a couple of points on that. I guess, as Chris has rightly pointed out, this is a significant risk across the country, and the point around the shift from analog to digital is envisaged to heighten that. This currently sits, as far as I'm aware, on the risk register, but I do think actually cyber risk and the nature of cyber risk, in that it is significant and it is external, may lead us to want to give some consideration when we move into the BAF for 25-26 as to whether actually this features as a strategic risk within our board assurance framework. That gives you that vehicle for your regular reporting on the controls and the assurances that, Chris, you have identified, and it feels right, given that you're developing a strategy, you've put governance in place, that it forms part of our consideration in the BAF. And then I guess the other thought, just in terms of governance, is the audit committee handbook is quite clear in terms of the role of the audit committee in its oversight of cyber risk, and certainly from a UH&M perspective, one of the things that I've introduced more recently is a report similar to that you've shared today, Chris, actually, that gives that kind of the national context, the controls and assurances in place. So I guess what I'm saying is just some consideration as to, potentially, putting into the business cycle for the audit committee some deeper assurance around what you've talked about today.
Claire, thank you for that. And Chris, I don't know whether you want to comment on that specifically now, but that would seem like an action to take away Claire's recommendation there to have an executive discussion and then come back to the board when that has been picked up through Julie, through audit committee as well. Yeah, okay, thank you.
Noted.
Yeah, thanks, Julie. Baz, welcome.
Hiya, thank you, David. I just wanted to say, Chris, thank you for that. It's really, really good. And as you know, I've been part of some of that cyber training with this board, and it's really, really reassuring. And this is more of a comment than a question, I suppose. It's just to say that it's really interesting to see, obviously, what you mentioned about the threats and how they're changing and how we've got to be ready for it. And it's really reassuring to just say how good it was to hear that you're talking about systems, talking to partners, talking to each other, and putting that in place. Because often when things go wrong is when partners are not talking to each other, and it's just really, really good to see that and hear that. So I just want to say thank you very much.
Thank you,
Baz. Thanks. Showkat, welcome.
Thank you, Chair. Chris, just to echo the comments other colleagues have made, thank you for the assurance. My question, and I'm not sure you're really going to be able to answer it, because by the very nature of it, it's about ransom demands. And, we've seen quite a lot of, and I was really disheartened when I heard that there have been organizations that when they've had a cyber attack and their systems have been hijacked, they've ended up paying ransom demands. I understand that central government are proposing to almost bring in some legislation which will mean that no organisation can or should pay a ransom demand. And I just wonder whether there had been any discussions centrally from the NHS around ransom demands and what the approach would be. But I accept it may be a question you don't publicly want to answer for the obvious reasons.
No, thank you, Shokan, and I think this is very much hot off the press, so I'm very happy to answer it, but I have very limited information. I think it was yesterday or the day before it was in the press around exactly that, which is potentially criminalising the payments of ransomware or ransom demands. So I think all I can say, Shokan, is we'll stay close to it and make people aware of what that changing legislation would be.
Thanks, Chris. Thanks, Shokat, for the question. Phil?
Thank you. So thanks for that, Chris. I just wanted to sort of close the loop and confirm the links through to EPRR, and this is very much part of the EPRR work programme for this year, ensuring we've got those strong links through. I guess the immediate thing for me, it's great we've gained such pace in terms of establishing the ops centre, the security ops centre, but then making sure that's linked through and working how that works out of hours for our respective gold and silver on call colleagues throughout the system. So quickly building those protocols, if you like, to make sure people are very well equipped to deal with these things in out of hours as well as in hours situations. Thanks.
I think that's a very important aspect, and you've picked up on it. The mechanics of the SOC, the Security Operations Centre, are fine, but it's about the processes and the people when these incidents happen, and that's what we are focusing on as well.
Thank you.
Yeah, thanks, Phil, for the question. Thanks, Chris. So just check if there's any further points anybody wants to raise before we bring this to a conclusion. And again, Chris, just excuse me, once again, on behalf of the board, thank you very much for bringing this forward and obviously championing this on behalf of the system. Really important piece of work. In terms of the recommendations, we will note the report, but I think it's more than that, actually taking the assurances from your presentation of the extensive work that's going on to try and manage this ever-present threat and to raise awareness. And I just want to build into that Claire's suggestion that there's further work through Julie Holder, our Chair of Audit, to look at how this and the risks are managed going forward. So, Chris, if we could take that away and in due course, if we could have a report back either through Julie from an assurance point of view from the audit committee or executive report, that would be very helpful.
Sure.
Okay, Chris, thank you. So if we could move into enclosure or item 9, enclosure 7, the quality and safety AAA report. There's two reports here. As I said at the start, Heather and Lynn unfortunately can't be with us. Josie is here as chair of quality and safety. Josie, I know there was no meeting scheduled for January. We've got some advance escalations in the first report and then your report as chair. Could I ask if you'd take enclosure 7 and 8 together and then we'll pick up any questions.
Thank you, David. So enclosure 7, as I say, we don't have a meeting in January because some of the issues we've got today, we have a lot of challenges with attendance because of all the pressures. So in terms of enclosure 7, I don't particularly have anything to add on that, but in terms of enclosure 8, which is my AAA report, some of the issues do overlap. So in terms of enclosure 8, from an alert point of view, we obviously raised some concerns about the ED harm review process. This links to Mr. Syme's question earlier, which I know we're going to respond to offline. I think there is a little bit more work to do around being assured that we've got full and early understanding of what's going on through our Derbyshire colleagues. And I know Heather and the team are working through that. And as I say, we are looking to put a new risk on the risk register. In the advice section, I was pleased, we spent some time listening to a presentation in relation to the intensive and assertive community mental health treatment review and plan. Now, it is an advise, and the reason that's in advise is not because of the level of work that's going on, because there's been a phenomenal amount of work gone on in response to this these issues and we've got obviously further work to do, which is why it's in advice, and we're going to get a further presentation back to safety and quality in March. But I just wanted to commend all of our colleagues that are working on that area for the fantastic amount of work they've done and a really engaging presentation to QSC. And then in the assure section, there's a long list of things that we were assured on. I'm not going to particularly pull any of them out, but I just wanted to show a little bit of balance, really, that we have got a lot of challenges and pressures in the system. We have got areas where we need to, you know, be very mindful of the pressures and keep our eye on the quality, but we have a lot of areas where we've got a lot of good work and a lot of assurance as well. So it's just a little bit of balance in the report that I just wanted to draw attention to the board. Thank you, David.
Josie, thank you very much. And just going back to the advices in enclosure 7, and just a couple of points, if I could. I thought I was really pleased to see the ICB quality team are supporting the university hospital, particularly around the impact of some of the waiting times and the pressures that the ED department's under at the university hospital. And colleagues will probably be aware the RCN have published a report today, which shows around the country just how acute some of those pressures are. So it's really important that we support our colleagues at the university hospital to maintain dignity and quality of care in times of great challenge, and that, you know, is what's happening at the moment as our winter plan resilience is being tested on a day-to-day basis. Josie, the second one I just wanted to ask, and not for now, just around the Darwin Centre, I just think it would be useful to the board to understand a bit more through quality and safety when you do meet, just in terms of the impact of that issue for the system. And Neil, I don't know whether you want to make a comment on that. I see you've got your hand up. Welcome, Neil.
Thank you, Chair. No, I just wanted to quickly brief on the intensive and assertive community services, because I know both Combined Healthcare and MPFT have done a lot of work. However, you probably know the report into Valdo Calcane, who was in the Nottinghamshire system, and the tragic deaths of 3 citizens. That report is going to be published imminently. I understand will certainly be published by the end of January, and I think all organisations will just have to review their position against that report.
Yeah, Neil, thank you for that. And I think that's a really important heads up. And Josie, again, with the RCN report, I know we briefly discussed that, and just making sure that as these reports are coming in, we are benchmarking ourselves against the inquiries or reports as they come forward. Bucky?
Yeah. So sorry, Pete. Sorry, David. I was just going to say, in terms of both of those items, yeah, that I'll be picking those up with Heather when we catch up again next week, and we'll provide further assurance to the board in due course.
Thanks, Josie. Bucky, welcome.
Thank you, Chair. I just wanted to give assurance and welcome what you've said around the report around Darwin Centre being taken through the Quality and Safety Committee. But just to give an update, if you like, that there has been a further meeting, and where ICB colleagues as well as the West Midlands provider collaborative were involved together with us, and that has been very, very positive in terms of it is good, it keeps us on our toes, but it also highlighted the importance of having the same definition for escalation, which isn't the case in here. But yeah, we'll do that.
Bucky, thank you for that. Really helpful to have that added clarification. So if everybody has had ample opportunity to ask any questions on the report, and Josie will obviously get a fuller report from the committee as it meets in due course. We'll just move to the recommendations if we can. I've got a number I just want to go through. We're being asked to receive the report on enclosure 7 first and seek further action as appropriate, which I think we've done. Be assured in relation to key quality assurance and patient safety activity undertaken in respect of matters relevant to all parts of the integrated care system, and importantly, to ratify the decision of the Quality and Safety Committee with regards to the continuous quality improvement framework. And then on Josie's report, enclosure 8, we're being asked to note the Quality and Safety Committee approved that continuous quality improvement framework. The Quality and Safety Committee approved the SEND Quality Assurance Framework, Quality Assurance Methodology, and the Quality and Safety Committee approved the VCSE Alliance Memorandum of Understanding. So, Josie, does that cover off all of the recommendations that you require from today's board? Thank you.
Yes, thank you, David.
Okay, so we'll move into item 10, enclosure 9. Paul E.J., you're going to cover this off in Rachel's absence. I think the escalation report from the Care and Health Senate.
I am. Thank you very much, David. I'm going to take the report as read. I think it's fairly straightforward. Just to highlight that, as often happens, although we are in January now, the date of the meeting I'm reporting on was in December, and some of the things that were coming through dated back to September. So it does take a time to get some of these things through to board. Using the 3A report, we've got nothing to alert the board to. There are a number of items under advise. I'm not going to go through each one of those, but I think there are a total of, just reminding myself, total of 6 items under advise. And I think the only thing that I would really want just to highlight there is not the content, but the breadth of what the Health and Care Senate is looking at. It's very much looking at demand management, at clinical pathways, at medicines optimization, and it's a very broad agenda. It also links back into, I was asked in finance and performance, just to bring back a short report, assuring the committee about the involvement of clinicians in the work on the medium-term plan and recovery and so on. And 2 of the items in here underline that. We've got an item on the medium-term plan and looking at the mitigated modelling, and then we've got an item on demand management collaborative and how that's working. So just an example there of how the agendas are linking together, and we've got clinical and strategic link together in that. There's nothing particularly under the assure. A note that we see the SBAF and the risk register for information twice a year, and then at the end there's a number of things just being escalated to others in terms of what's been approved. So that was all I was going to say, David. I can see there's one question, if you want me to take that.
Yeah, thanks very much, Paul. And I just want to quickly comment on the point you made there about the breadth of the agenda. We've said this at a number of boards now. It's really helpful to get this report linked to the quality and safety report and the wider engagement with the strategy underpinning, those decisions we are taking, particularly when money and finance is tight. So we're getting the right balance of making sure we are keeping patients safe first, and that comes paramount in our decision-making process. So really helpful report. Julie?
Thank you.
Thanks very much. Thanks, Paul. I do think it's a really good report, and I was going to ask a question about how things are all tying in and clinical involvement within the planning process. I think you said at the beginning of your presentation there, Paul, that this was the December meeting, and so my question was the guidance that came out around weight management drugs, which was late in December. Obviously, I think probably the Clinical Senate has not actually met to talk about that, but the implications for that in terms of rolling it out from a planning point of view are so important. And I just wonder how we're going to bring that into planning, into that Clinical Senate and into discussion at board.
Thanks, Julie.
Yeah, thank you, Julie, for the question. Yes, the weight management drugs offer us both a wonderful opportunity in terms of health and well-being of the population, and managing our health services, but they also provide us with an enormous headache. Because the extent of the NICE tag, the guidance that's come out, which of course is mandatory for ICBs and organisations to implement, the implications are enormous. We've set up a very clear working group, which is working across 2 or 3 of our portfolios at the moment, working very much with NHS England. There are almost weekly webinars at the moment with the national team, looking at how we're going to do the prioritisation for this, because the rollout is going to be over about 12 years. So there has got to be a very clear prioritisation in that as to who comes first. It can't be just who comes along first. It can't be just who shouts loudest first. There's got to be a very clear who are the priorities to bring forward first, and then how do we roll that through? How does the funding work? What comes from national? How do we get the drug reimbursement, etc.? And it's all got to be very, very carefully worked out. So we are working as fast as we can on that, given that we're still missing quite a lot of national guidance on this in terms of prioritisation and so on. As soon as we can, we will take something back to Senate, probably to the next Senate. I think we've already done a little bit of an update, but we will do a bigger update. And I think when we can, we will bring something back through Strategic Commissioning Committee and then up to board as appropriate. Does that help? I think it's just early days yet, but there is going to be a lot of work, a lot of questions asked of us. We're probably going to get a lot of complaints by people who don't understand why they're not in the first group of prioritisation. We've got a significant number of people already getting these medications privately, and they're doing that without the dietetic and psychological wraparound that we should be having. So it's an awful lot in that, but we will be bringing it back through.
I just thought it was really important, Chair, because there's so much press, and for those people who this is relevant for, it's really important to understand the complications as well as the enormous benefits as well. So thank you very much.
Thank you.
Yeah, Julie, thank you. Really, a really helpful question. Neil?
Thanks, David. Thanks very much. Can I just celebrate the work that Dr. Kiddy has done, Farah Kiddy, in particular around frailty? And just to say, I think there's a lot of science involved in that paper that she's produced. And for me, if we're really going to tackle a different winter next year, I'm sure this board would agree, severe frailty has to be an absolute priority, and I think we need to continue to work. We've got Farah for another 3 months. We found the funding, so I think we've got a real expert in our midst, and I think colleagues will be aware in her own right she's a GP in the Leicestershire area, so she brings a lot of skills to the table.
Yeah, thank you, Neil. So Paul will note that, and certainly Neil's point there about the frailty piece, critically important on all fronts, actually, not just winter, as we move forward. So thanks, Paul, for covering that off for Rachel. Just check if there are any further points any member of the board wishes to make. If not, we'll once again move to the recommendations, and we're being asked to note the Health and Care Senate approved the decisions summarised in the Integrated Medicines Optimisation Management Group from October 2024. The Senate approved the Healthy Ageing and Frailty Strategy. The Senate also approved the All Age Respiratory Strategy and the Breathlessness and Upper GI Pathways, and it also approved the Lower Back Pain Guidance. So with those recommendations, we received that report and move on, if we can, Paul, into enclosure 11, item 11, enclosure 10, and then Josie, I know you're covering off Megan's escalation report at enclosure 11. So Paul, if I can hand over to you first,
thanks,
and then to Phil on the performance side.
Yeah, great, thank you. Yeah, David, you earlier referenced the enormous clinical challenges, and they're mentioned by Josie too, that we're under, and of course those are manifesting themselves in terms of financial pressure too. So it continues to be a very, very, very challenging financial year. In that context, the position in month 8 was relatively positive. It was the first month this year that the system has actually achieved a surplus. It was a small surplus, but our cumulative deficit went from 33.7 million to 33.4. So some signs that some of the measures that we're taking are starting to have an effect, which I'll touch upon. Just to remind the board of the journey we've been on. We started the year with significant amount of risk, which quite early in the year, some of it crystallized, particularly the payments to out-of-system providers. So we were looking at what we call unmitigated risk of 100 million. So that was potentially 100 million miss of our target, or a deficit of 100 million. The report signals that we are looking to get towards. We've identified measures that get us towards 56 million. If you remember last month, we were talking about achieving that 56 million, which was essentially the green and amber schemes that we took from the recovery program that we developed over the summer. That got us to 56 million. Since that was agreed, it was agreed by the national team that the dental any surpluses on dental would be withdrawn or pulled back to the centre. And that meant we had about an £8 million gap against that 56 million. So in that context, we've now managed to effectively find that 8 million. We've covered that off now, and we're forecasting 56 million. And I'll come on to options to reduce that further in a second. But first, just talk a bit about the investigation and intervention, the I&I regime that David, Peter, you mentioned at the start. That is so that was commenced in the summer in about August, and we have had support in place since then, as mandated under that regime, and it is proving helpful. I think we are getting somewhere on a number of fronts. So the four odds mentioned, workforce is a big part of that work stream, and clearly we in a position where we've got less money going forward. We have less money, therefore, as workforce is our biggest cost at the NHS as a people organisation. Clearly, the numbers of people that we can afford to employ across the whole system is going to have to reduce going forward, we think. But we clearly need to find ways to do that in ways which are safe and beneficial to the patient pathway. So that piece of work has really been looking at how does each organisation make its decisions around workforce in the round. Because it's not just about hiring, it's about how can we get the most from the workforce that we have. For example, reducing the cost of agency and having more substantive. We've been successful in that regard, but we have seen some overall growth in the workforce, which is not affordable, I'm afraid. So that's a key area for the I&I work. And the next agenda item, David, on workforce and people is going to be picked up by Mish, so I'll leave it there. And I'm sure Mish will pick up on that. The second part of the I&I regime is particularly focused around the CHC continuing healthcare service that we provide, and pleased to say that there really is some significant improvement there. And we, from the outset, we've said and say again that reducing CHC costs is actually a good thing, because what we're looking to do is make sure that people get home as quickly as they possibly can. That's what they want, and on this one that then saves money. So it's genuinely a win-win when we can achieve that. So really pleased to say that we've seen a 12% reduction in the CHC caseload, which is effectively 12% of people going home, which is great. We haven't yet seen 12% come through in terms of the money, but we're starting to see it happen. There is an inbuilt delay because of the process of moving patients into different pathways. But that work stream is looking really positive. Currently working on the whole pathway position. We've got the I&I team, Deloitte, still supporting us, looking at that for us, looking at the evidence of really where in the pathway is it successful, and where in the pathway could it be improved. So very hopeful on that one, that's going to deliver further benefits. The fourth area is around productivity, and particularly focusing there at UH&M particularly on the elective process. How many patients can we bring into operating theatres? How can we maximise the way that we work with the independent sector to make sure the right patients go to the right organisation? And we think there are opportunities there, and we're finding opportunities there to both increase the number of patients that we treat, but also reduce the overall cost. Fourthly, clinical optimization. You referenced before, David, quite rightly, the importance of the work of the Health and Care Centre that Paul leads. Paul is leading that work stream to really look at where is the services that we have that we provide that are potentially less optimal, what are the ones that are most optimal, how do we make sure that we get that right balance? And then finally, work on the balance sheets, where we think we've still got some opportunity from previous costs that have been accrued to balance sheets to potentially release some of that into the position. All of that is reviewed every evening, 5 o'clock. We take one of those subjects, and every Monday the chief executives meet together. So we've got really rapid escalation. We've got real commitment from the whole system to this, and as I said earlier, it is working. So we, as I said, have seen that improvement in the run rate, and we have reduced the risk around the 56 million. That's good. The problem, back to Julie's question at the outset, is that 56 million is not nil. We have been told we must get to break even. So I cannot give the board assurance today that we will do that. I do feel, myself and my CFO colleagues do feel, that some of the actions that I've described are still going to flow through into the position in year. Clearly, we're running out of time as we head towards March, so there's only so long to go. But we do expect, I do expect and hope for some improvement on that 56 million in the months ahead. Whether we can get back to break even, David, we don't yet know. We've been told very clearly by the centre that we must, and I can assure the board we're doing absolutely everything that we possibly can to do that, whilst clearly maintaining safe services as we do that. So I'll probably stop there, David, and see if there are any questions.
Thanks, Paul. John?
Afternoon, everybody. Just want to talk about the continuing healthcare and ask a couple of questions, Paul. Realising asking them, they may not be entirely for you, so feel free to field them, Chair, as you wish. Clearly, a reduction of 10% or 12% in number of people receiving continuing healthcare is quite a dramatic reduction. 1 in 10 people who would have been getting continuing healthcare are not going to get continuing healthcare in future. And that might be right. It might be that historically we have over provided, but of course it's not without risk as well. And my question is, are we going to be tracking the key indicators around the cohort we're turning down to ensure that we are not doing any harm to those individuals? And I'm talking particularly about rates of readmission of those individuals to hospital. Because if that starts to go up to that cohort, then that would raise questions as to whether this significant reduction in access to continuing healthcare is being done safely.
John, thanks for the question. And Paul, just mindful, you may be able to pick some of that up, but you might just need some assistance.
Yeah, I'm sure I will, and Heather would be the person I'd look to, but she's not here today. I mean, I can absolutely give reassurance to John on the questions that he asked, though, because this is a clinically run team. This is not financially driven. It's run by Heather and her clinical team, and can absolutely assure John that every single decision is taken in the light of the best interests of the patient. And that's why, I mean, we have to remember that we still are a massive outlier. So as a system for per capita population, we have the highest CHC spend, which is obviously not good financially, but it's not good from a clinical perspective, is it? So, we know we start from a high base. And so whilst, as you say, John, 1 in 10 is a significant proportion, actually it's just taking us back to where we should have been in the first place. But in terms of those clinical measures, yes, again, can give complete reassurance that all those things are being looked at by the team. And that, I wouldn't anyway, but if I tried to, force on the team certain actions to take for financial reasons, they would not take them. They make the decisions on CHC assessment absolutely on the individual clinical needs of that patient. And I would like to say thank you to your colleagues and from the county too, because it is a joint effort, and the collaborative that I mentioned is wider than health. It is about working together, because clearly we need to see the journey of that patient in the round, not just the health part, but the social care part as well. So, as I say, I can give my personal reassurance, John, that it is absolutely a clinically driven process.
Yeah, thanks, Paul. John, what we'll do is also just ask Heather to confirm that, because I think those curious questions, or question you've just asked, is really important. And as Paul described as he was concluding his presentation there, the clinical care drivers behind this have to be paramount. That safety comes first, and that we are monitoring that really, really carefully and really insightfully, with that curiosity that you brought to bear this afternoon during the discussion. Julie, I noticed you had your hand up and now it's gone down. Do you want to still come in and make a point?
Yes, please, if I could. I pressed the wrong button, sorry. It's just following on from John, really. What I was thinking, not necessarily just about continuing healthcare, but because of the pressure on the system, in terms of being able to assess harm or the impact on patient experience. I wonder if as a board we could have it as a board. It does come, some of this comes through audit committee, some of it will come through other committees, is looking at things like complaints and freedom of information requests, because there's been an awful increase in volume, is just looking at it to understand the impact of that. And my second question was just around, we are fast running out of time now. We meet as a board every month formally, and I just wondered if we might need, well, I would suggest we might need to meet in an extraordinary format in order to look at the financial position and the implications of that as a board. I know there are lots of areas of governance, but as a board to actually look at the likely outturn position as we get closer to the end of the year.
Yeah, thanks, Julie. If I could deal with that, absolutely. We've got the flexibility to have an extraordinary meeting if required to make sure that we've scrutinised that point. And the other point, just Paul, before you might want to make a comment as well, on the complaints and freedom of information at requests, I think, again, really important question. And Peter, just before I bring you in on your question, I just wanted to refer to the covering sheets for the board papers and just highlight that there are two points on there about any financial impacts or any impacts on the ICB undertakings, and perhaps there's a box missing there in terms of the quality and safety piece, having looked at it again in preparation for the meeting. And the other thing I'd just say to the executive on the call, writing the papers, there's a lot of those reports have got no ticked for the impact on those 2 points I just raised. And I think, Peter, through the executive discussion, I think it's worth revisiting that, because obviously, as we've described through the work of the Senate and the Quality and Safety Committee, etc., there's a lot of interconnections here that we need to keep a very, very close eye on as we're moving forward. So if we could just note that as an action, Peter, to take back and have a look in the executive with those front sheets. But Peter, you come in and ask your question.
Yeah. Well, I'll take that away for sure, David. So it was more of a statement, really. So it is unfortunate that we haven't got Heather here today, because there's a couple of strands of conversation there orientated around quality more generally and specifically CHC. And as most will know on the call, Heather is executive lead for CHC within the ICB. So what I think it's worth doing behind the scenes is just to ensure that the linkages between not just CHC and the unintended consequences risk, I think that John mentioned there, but more generally, decisions going forwards that particularly linked to 25-26 planning are effectively being taken through, discussed, debated at the quality committee, but then of course up through to the board. So we'll, in the background, we'll just do that check to make sure that the mechanisms are absolutely firmly in place, both in terms of the CHC specific point, but also more generally, particularly planning around 25-26 as we enter into what potentially are going to be some tough choices.
Yeah, thanks, Peter. And if we could also just formally note Julie's point about the need potentially to bring the board together to just provide a sign off and oversight to that. That'd be helpful. John, I noticed your hand shot up and then shot down. Was that pilot error on the button, or did you want to come back in?
No, it was just a really small point, really, which is why I took my hand down. But I will add it now you brought me in, which is another measure to add to the ones that have already been given, which is good to track, is actually appeals. So if we start losing a higher proportion of appeals with respect to CHC, then that would also suggest that we are getting it right. So that's quite important.
Yeah, John, thanks for that point. Really worth making. Paul, assuming there's no further points on the finance specific aspects of the report, do you want to bring Phil in just to take us through the performance aspects before I hand over to Josie to do the exception report?
Thank you. Thanks, David. I'm going to focus my update today around winter, just sort of trying to tell the story today to where we're at and how we're looking to take it forward over the balance of the next few months. Firstly, I think it's important just to look at the national context. So I guess everyone's seen the press, etc., but national data has shown that last calendar year, was the busiest one ever for A&Es and for ambulance services in England, and December, I think, had the highest number of ambulance conveyances that we've ever seen in 1 month. The latest weekly data, or at least the data that I've seen, shows that flu is 3.5 times higher than the same period last year, and obviously flu sits alongside COVID, RSV, and other sort of seasonal illnesses and things that are impacting as well. And then across the country, a number of trusts and a number of systems have declared critical incidents over the period of the last couple of months, citing the exceptional demand and respiratory viruses in particular impacting on their ability to deliver care. So that's the national context. I mean, our local context very much mirrors a lot of that, in that we saw a rapid rise and spike of pressures very early in the winter season, resulting in a system-wide critical incident being declared at the very end of November. That was stood down early December. However, we've had further periods of CIs at both UH&M and at the Burton site since then. So there's a few ways to look at this. In terms of demand, as I talked about earlier in response to that action on the tracker from last time, demand certainly, when you compare months this year to months last year, is dramatically different, but broadly in line overall year to date with where we thought it would be. Therefore, this is more around sort of specific periods of intense surge rather than an overall picture for the year. I mean, within Royal Stoke, both November and December saw 5% higher demand than the same periods last year, but it's even more pronounced actually in our type 3. So, for example, Hayward Walk-in Centre was over 9% higher in December 24 versus December 23. From an infection perspective, we had some real spikes in norovirus in November, which were really quite a heavy contributing factor to the critical incident there. And we are seeing what for us so far is our second highest seasonal flu demand in recent years. It's the second highest cumulatively at the moment, so it may be that I'm coming back in a month or two once the flu season's over and saying it has turned out to be the highest, but it was certainly unique in terms of the very early presentation of flu and a very high surge in terms of flu presentations at the end of November. So IPC continues to be extremely challenging for us into January, with varying degrees of COVID, RSV, flu and norovirus doing the rounds concurrently. At the moment, it seems like at least that we've hit the peak of flu A. We know that flu B is coming in the next month or so, and we're also being told to expect a further surge of COVID as we head through the next few weeks. Acuity spikes have been a problem for us, particularly over the New Year period, when our majors and trauma stroke resus demand was much higher in terms of proportion of demand coming through the door than we would traditionally expect. And we've had some days of really high ambulance arrivals. So, for example, Royal Stoke on Monday of this week had 179 arrivals, which was the highest I could find since August of 2021. What this all translates to for our population is that there's been some really unacceptable delays across the entirety of the UEC pathway. Notably, this has been seen in terms of ambulance response times, which for category 2 deteriorated to 39 minutes on average in November, and we're expecting the final December position to be over 50 minutes. Ambulance lost hours outside of hospital have obviously been a contributing factor to this and have remained really high, impacting on all sites, but especially Royal Stoke. So the situation that presents really is one that compromises patient care, and I think we all agree is completely unacceptable for everyone involved. At this point in time, system remains in high escalation. UHNM is still in a business continuity incident as of today, although we're reviewing that later on this afternoon. In terms of response, we've deployed the surge plan that we agreed as a board in November, and in response to the earlier arrival of winter and the greater than expected pressures at certain points, we've taken some additional extraordinary actions. So, for example, we brought forward primary care winter hub capacity into November, which was previously scheduled to come online in December, and then also boosted that with an extra 600 appointments per week from early December. We also brought forward community hospital bed capacity, D2A bed capacity, with further super surge as we've gone through the winter period into some extra beds there, plus a peak of 65 spot purchase D2A beds in response to the demand that we've seen. A real success that we have had actually is around the further development of our single point of access, the ICC. So additional staffing have been deployed into there. We've had a 20% increase in demand over the last month going into there, and we're also the first system within the region to go live with a 24/7 offer for a single point of access for care professionals from the start of January. We've got an absolute focus around our care home population because we know traditionally conveyances from care homes are higher than you would expect in our area. But through working with those care homes, promoting that single point of access, building trust in that model, and then additional capacity to support visits out to care homes over the last few months, we've seen some really positive responses there around that care home population. Obviously working with our ambulance services as a really key partner in all of this, to promote the use of call before convey. And I understand that next week that's going to move to being a 24/7 model from the ambulance services perspective, and also the age boundaries for that are going to be reducing. Previously it was over 60s. It'll be all suitable adults now will be considered for call before convey. From the hospital perspectives, we've worked towards rolling out the 45-minute ambulance handover protocol to ensure that delays in handover are minimised, but obviously that's been heavily compromised by the pressures that we've seen. Within the acute footprint, we've had to take some decisions around the risk assessed use of your next patient, so essentially boarding onto wards, use of corridor, in order to sort of balance that risk across the footprint. The pressures though have meant that there's been a significant stand down of elective work, particularly over the last month, and that's to respond to the pressures both from a medical perspective and trauma. So there have been some cancellations as a result, and we're trying to mitigate that, rebook patients as soon as possible, and we're trying to work to secure some additional capacity and mutual aid from other NHS partners in terms of helping us recover that position again. It's not just though about raw capacity here in terms of opening beds or adding extra people in here, there and everywhere. It's about the way that we work. So we've worked as a system very effectively, I think, over the last 2 months to provide regular multidisciplinary in-reach into the hospital settings to support colleagues in the hospital identify patients suitable for discharge and to support speedy discharge and transition for those patients to onward services. We've also done enhanced in-reach into UEC portals to try and identify patients there who can go home with some level of support, but not needing to go through an inpatient pathway. And I think UH&M have taken some really strong steps in terms of their own processes. They've invited NHSE national team in to review their internal UEC pathways. And as of this week, they've brought in an internal UEC improvement director to lead their internal programme of improvement. I think I should also say that the pressures have been really relentless for our workforce at all levels, and we have seen increased sickness absence levels across all of our partners in the system. We're carrying out a series of formal debriefs and data reviews as we work our way through winter. We took the first one of those through to Finance and Performance Committee at the start of January, and this will be an iterative process, so I'll take something through in Feb again and then in March again, and then that will build together to give us that sort of full review of winter and support the formal learning event that we hold in the spring. So really challenging situation, but I did want to assure the board that the leadership community across the system has functioned really well. There's been daily conversations, whether it be bank holidays, weekends or whatever, including all NHS and local authority partners, and everybody continues to work collaboratively and supportively to try and navigate the pressures that we continue to experience. Thank you.
Phil, thanks for that. And I think the pressure, was palpable there, that you brought that to life as you've gone through the report. Phil, the only thing I'd got to ask just before I open it up and obviously then bring Josie in was just on page 3, the overview of key ICB performance October 24 slide. That's in there, and the one that follows it, just in terms of the red we are now picking up on that metric or dashboard, where we are underperforming against the plan target and variance to plan or target. Presumably some of that is linked to the elective stuff that you referred to, and clearly the ambulance issues associated with winter. I just wondered, how that is overall being managed, and particularly, as we look forward to our quarterly review with NHS England, etc., just to make sure that we've got a grip on those reds, recognising why they're occurring, but being able to predict when we will see more green.
Yes, no, thank you. And we've got daily strategic calls in place that are essentially looking through those metrics and trying to balance decision making in the context of those. So although we've seen deterioration around elective, I think with some of the external support we're looking to bring in, we should be able to recover that during the next few months. But certainly some of our year-to-date metrics, particularly around the ambulance response times, A&E 4-hour performance, will be difficult to recover, but it's going to be about understanding the drivers and causes of those, and then be able to sort of bring that together into a narrative for when we meet with the region.
Yeah, thanks Phil. So just pause in case there's any immediate questions there. If not, Josie, can I hand over to you to cover off Megan's escalation report?
Yeah, thanks David, and thanks to Paul and Phil. Obviously Megan submitted a very comprehensive report, which I'll take as read, and obviously with the narrative from Paul and Phil, a lot of the key areas have been covered off, but she did ask me to raise just one or two things, David, if that's okay. So whilst we've spoken about the financial position, I think from a chair of the F&P committee point of view, I think Megan wanted to just emphasise that as we sit here today, we don't have a route to the break-even position clear at the moment. Whilst things are improving, we were still concerned about that, and the I&I process, whilst it is identifying savings of around 1 to 2 million per month where we are now, that won't take us to where we need to be. So really pleased to see some of the improvements, but still quite a lot to do, and I would concur with Julie that a conversation at board level is hopefully will help to support us through that. In terms of UEC performance, I think Phil's covered all that off. The only thing I would add was that we did have a presentation from the Integrated Care Coordinator coordination team, and we were very impressed with what they were doing, and Phil's described some of the outcomes from that work and how that's been taken forward. So that was seen as a really good presentation, really good initiative, and really crucial if you try and bring finance and quality together to getting the right patients in the right service at the right time and keeping more people at home. So the quality and financial aspects and performance aspects coming together. There were a couple of things that we did approve. So we approved the modification of the pulmonary rehabilitation service to be pulled together to a more comprehensive and equitable service for patients, although there's more work to be done in terms of how that will work in practice. The principles, I think we need to be clear, it was the principles that were agreed rather than the detail. We agreed a contract for the acute visiting service in the committee. Again, that's outlined in the report. And then the only thing that's not been touched on is we remain concerned about the capital position for 25-26 and the clinical risk related to this, and there'll be a focus on this at our next committee, and it will come through the highlight report, the AAA report to the February board. Thank you, David.
Josie, thank you very much for that very helpful update. So just in terms of the recommendations for today, if we turn to enclosure 10, we're being asked to acknowledge the high level performance against the 5 priorities, acknowledge the high level key programme deliverables update, and acknowledge the current financial position. Paul, just in response to Julie's point, we'll just note, I think there's a recommendation as well, the timing of the board meetings to be able to make sure that we're taking a decision either around altering our prediction on end of year position with the centre in due course, so we've got that flexibility to bring that in. And then just on enclosure 11, Josie's report, we're being asked to receive and note the update. Okay, Paul, that gives you everything you need, and Phil, for today. Yep, thank you. So if we can move then into item 12, enclosure 12, Mish, can I ask you to join us and take us through the People, Culture and Inclusion Committee report, and then we'll bring Showkat in as chair for enclosure 13. I take it Mish is on the call?
I am. Can you see me and hear me?
No, I can now, Mish. Welcome.
Oh, you can. Okay, that's great. I hope everyone else can. Please do let me know if you can't in the chat. So I was going to say that from a workforce perspective, I was going to move on from Paul's conversation regarding the financial position. There are some real positives with workforce, and they continue to carry on in terms of the turnover. We have only got 8.6% turnover, which is really positive in terms of our workforce wellbeing. Our agency figures are 2.3%, which is against a target of 3.2%, which is really positive and a credit to all the providers in terms of the work that they've done around productivity and our processes. However, we do remain over our operational planning figures, and that obviously will have a financial impact for us. We're 467 over our operational plan. The majority of that does sit within the acute, that's linked to some funded activity and ERF. And there are a number of other areas where they've had to increase their workforce. What we will need to do in the next 12 months and going forward is to consider very much from a productivity lens how we can support the increased use of workforce where we need it and reduced workforce where we can be more efficient and we can have our workforce working in the right places. In order to do that, there's a number of different programs. As Paul has referred to, we have the I&I team in. Within each of the providers, the I&I team are supporting them to look at a number of different processes. They have financial control recovery groups with them every week, a numerous number of them in some of the providers, to consider not just the vacancy control, but also establishments, how workforce is being utilised. Those control groups are clinically led, so they're very much focused on patient safety and also the productivity changes that we could put in place to make things better for the workforce from a wellbeing perspective, as well as being more efficient for us. You'll see as well in Showkat's report as we move forward, our approach in our PCI committee is all about how we can help our workforce to be trained to be able and capable, and help them from a HR perspective to be able to move across the system and to work in a different way. This is something that we've been working on for some time and will continue to do so. But our hope and our aim is that we will have a healthy workforce that are able to support our population, but in the most productive manner. I think I'll stop there, David, unless there was anything else you wanted me to say at this point, see if there's any questions.
No, thanks, Mish, for that. We'll just pause while I'm asking Showkat to come in and do the escalation report. Showkat, let's do that. Bring in your report, and then we'll see if there's any questions when you've done that.
Yeah, no, thank you, Chair, and thank you, Mish, because I think Mish has comprehensively covered most of the discussion we had. So there are no alerts that I need to feed back on, and the only other things that I would add is that we had a bit of a focus on health and well-being of the workforce, and we spent quite a bit of time on that. You'll see from the report itself that funding has been secured for the ICS Staff Psychological Wellbeing Hub, which I think is some fantastic work by everyone within the system to make sure the importance of that work continuing. And then just finally, there was a staffing story which I really do want to share, which was around the ICS Future Leaders Placement Programme. And Corinne, a paramedic student, came along and spoke about the programme and what she has got out of that. And it really was about working across the system, end to end, understanding each other's roles. And I hope, Chair, at some point we can possibly share that with the board, because it was a really powerful example of working across the system, and I think it's really worth sharing. That's all I really wanted to say, in addition to what Mish has already said. Thank you.
Showkat, thank you, and we will note that actually if there's an inspirational example that does exactly what you've described, let's bring that forward and hear it in due course. So Lisa will build that into the forward cycle. So just check, are there any points of clarification on the report, either from Mish or from Showkat? Okay, looks like you've covered it off very comprehensively, Mish, there. So well done. So we are being asked to note the workforce position, operating plan risks and mitigations in place to address, and also to receive and note the update from Showkat's assurance report. Thank you very much for that. Showkat, can I ask you just to deal with item 13, enclosure 14, the remuneration committee exception report as well, please?
Yeah, thank you, Chair. I'm going to take the report as read. So there are no issues from an alert or advice point of view. A number of things discussed from an assurance point of view, within that including the appointment, which I know, Chair, you've already mentioned, to the vacant non-executive member. We also spoke about a partial retirement, which again is highlighted there, alongside the chief executive's appraisal process, and then the annual pay review as well. All of that is there summarised within the report, Chair. Thank you.
Thank you very much, Showkat. We're being asked to receive and note the update. So we'll move straight into item 14, enclosure 15. Claire, you're going to join us for this. And just to alert the board, Julie Holder has asked at the beginning of the meeting if Julie can just do a very quick update from an audit committee perspective as well as part of this report. But Claire, can I ask you to join us first?
Sure, and thank you for that. The BAP that you see before you today has been through the usual process, and I think at this point, you know, real kind of credit to Paul and his team for all the work that goes into pulling this together, along with the input from executive colleagues. I, you know all too well how much work goes into this. So thank you for that. Hopefully the executive summary is comprehensive in terms of key points. Just a few to pull out. Top 3 risks, so scoring of high 20, are reducing health inequalities, financial and workforce sustainability, which I hope the board can relate to, and it certainly aligns with some of the conversations that have taken place today. We haven't seen any changes in risk level at Q during this quarter. In terms of assurance, 6 out of 8 of the strategic risks have been given a partial assurance rating, whereas 2 out of 8, which are quality and workforce, have an acceptable assurance rating. So just linking that into the point later on in the paper in terms of the work to be done around the business cycles, it just presents an opportunity for committees to really consider, if we are seeing partial assurance against these risks, what's the gap that we need to address in terms of assurance to those committees. New this time is the introduction of trajectories for risk reduction. Again, another positive development, and you'll see they set out where we expect the risk to be at the end of, well, in the Q4 report. Hopefully, this serves to provide a line of sight in terms of when we might expect to achieve the level of risk we aspire to, and also gives an opportunity to reflect on the actions that are planned, and actually are those actions identified in the BAF really going to get us towards the risk that is set out within the trajectory. So you know, a focus on the adequacy of those actions. Just as an aside, so the board will be aware that our SBAF has received some national recognition, and I'm pleased to share that Tracy Shewan and I were actually invited to sit as panelists on a national audit committee chairs session in November, where we talked about the work that we've done as a system around board assurance, and we really managed to spark some interest. And we've had people contacting us from other systems wanting to, you know, learn from what we've done here. So I think it's important just to recognise that. I guess linking to the conversation we had earlier on under the cyber point, I think as we approach the end of the financial year, we will want to start thinking about, you know, what does the shape and content of the SBAF look like for 25-26. It may be that, you know, it stays the same with some tinkering around the edges. We might want to bring in new strategic risks, for example, cyber. So I think board need to be, I guess, open to having a conversation around that at some point soon. And then I guess an area of development, I think, potentially for exploration within the 25-26 BAF is a couple of points. How we kind of summarise the operational risk in a way that is meaningful, and that may be through the use of AI or an alternative, but actually how do we summarise all of the quality risks on the risk register, and therefore what does that mean for the strategic risk? So a bit of work I think we could potentially do around that, and I think that's all I want to say at this stage, David, unless Paul wants to come in, or any execs, and of course, as you suggest, Julie.
Yeah, Claire, thank you so much for that. And it is important that we celebrate as well where we're getting things right. So congratulations to you and Tracy that you had that opportunity. And just before I bring Julie in, that point you made about the gap analysis around the partial assurances, I think is really important. And you say, you know, this is a timely time to actually undertake that. So I think between yourself and Julie, just thinking about how people who are chairing committees, including the board, you know, how we actually gain from that expertise to make sure we're reinventing our processes to make sure they are fit for purpose as we move forward is really, really important. So I really welcome that. Thanks, Claire. Julie.
Thanks, David. If I talk about risk first and the SBAF, because we spent some time at this audit committee, and then with if you will let me just go on to talk about some of the key things. The discussion at audit committee, and it applies to SBAF, is there are some risks that are not moving over 6 months. And I think you've mentioned it there, Claire, absolutely. As far as audit was concerned, we've referred those back to those committees to challenge whether they're the right mitigating actions, whether we're not doing enough of them. But it leads on to actually look at whether we're actually tolerating those risks and asking people to look at their target risk scores. If you look at the SBAF in particular, I think, unless I'm misreading this, because the figures were small, on SBAF 2, we're talking about it being 6 by the end of the year. That's not going to happen. And equally, I would question whether health inequalities, given the constraints that we have and the speed at which these move, whether that's going to get to the target score. So those sort of comments were made at audit committee and they've been recorded accordingly. I was going to stop there before I go on to audit committee, David, just to see if anybody else wanted to ask Claire about risk, about SBAF.
Thanks, Julie. We'll just check if Claire, do you want to come back on anything Julie's just said?
Yeah, it was just an added point, really, just thinking about the insightful board, which hopefully people will be familiar with, but I guess a greater emphasis, more so than ever, on triangulation of assurance. And so, you know, very, very conscious that, you know, many SBAFs look at individual risks and the individual assurances relevant to that. And we've heard a couple of times in today's conversations, for example, you know, the impact of our financial position on quality and safety, the impact of our financial position, for example, on workforce. So whilst I don't have the answers, I think there's certainly something that we need to be doing to, I guess, cross over where appropriate the assurances that might be seen in one committee but might be relevant to another. So again, another perhaps piece of work and conversation that Julie, myself and the governance colleagues might want to have.
Yeah, I would say most definitely. And Julie, I noticed you were nodding there. I think that's a piece of work that, you know, we do need to do. So I'd ask that is commissioned. Okay, Julie.
Thanks, and thanks, Claire. Unfortunately, the meeting was earlier this week, so we didn't have a chance to get an assurance report here today. That will come in time. So you haven't had a chance to look at what was going on in audit committee this week. So there are just a few things I'd like to mention, if that's okay. One was around risk, also confirmation of the reappointment of Grant Thornton as our external auditors. To note that the compliance level against EPRR national standards is now substantial. There's a great deal of work and good work that we want to acknowledge around that. There was some partial compliance in 3 areas, including business interruption, and we need to reflect. We ask that we need confirmation that we're going to reflect the learning from recent critical incidents, and Phil mentioned that earlier. We talked about the final accounts timetable. We will approve that at board in June. We had 3 internal audit reports. Green plan was reasonable, key financial controls was substantial, and we had an advisory report on personal health budgets. This audit related to historical transactions, and arrangements have been improved since then, but there were a number of recommendations, and so we're going to have a deep dive into those recommendations at our next audit committee. And just talking about that, because we had a report last time around population health, we had a deep dive and a great presentation around population health, not only in relation to the audit recommendations, but understanding of the wider scope of work, and an excellent summary around health inequalities, population health and prevention. And what we're seeing there is the firming up of governance arrangements around that, and including that visibility at board. We spent quite a bit of time talking about the alignment of the undertaking reporting with I&I. They're starting to come together. And also, and this is something that's going to be picked up in there's a board seminar next week, is around strengthening levels of assurance. One of the things that we talked about, and I've since spoken to Paul Winter about, is introducing 7 levels of assurance. I think it is really important for us to strengthen that, again, in the context of what Claire said about the insightful board, but our financial position as well. We reflected on the outcome of the review of audit committee effectiveness, and we're going to speak further to actually put in place some actions that will improve the effectiveness. Thank you.
Julie, thank you for that really helpful summary of the work. A lot of business transacted, obviously, at that meeting. and we look forward to the AA report coming back for information after receiving the verbal update. So if colleagues are happy to do so, we've been asked to discuss and confirm whether the Q3 risk scores and assurance assessments are an accurate reflection of the position, and discuss and confirm the adequacy of those controls and assessments. And I think we've done that, but I think Claire's and Julie's points just need to be brought out into the recommendations, particularly that gap analysis around the partial assurances and the timing now to get those right. And Julie's touched on a really important piece of work for the board next week as we go into that development piece around the governance and controls that we need to review for the year that's coming upon us very quickly, actually, the end of this financial year. So with that, we'll receive those reports with those recommendations. Thank you, Claire, for joining us and the work you're doing in regard to the SBAF. So we'll pause now if we can. Paul, can you join me, and probably Adele as well? And can we just check if we've had any questions come in online before I invite anybody joining us today to ask any questions on the items that we've covered on the agenda?
Thanks, David. So I've not been alerted of any, but Adele may be able to confirm.
Yeah, no further questions.
No further questions coming online. Okay, so can I invite any questions that any member of the public's got to ask the board today? Okay, Ian, welcome.
Sorry, Chair. Am I the only one?
It looks like you are, Ian. Yeah.
Oh dear, alone again.
I can hear you clearly, Ian, but I can't see you.
Thank you very much for an interesting board meeting. Could I thank Paul and Adele for my questions earlier and the responses earlier? Thank also Phil Smith for a very coherent, comprehensive overview of urgent and emergency care. I realise it's ongoing. I'm not going to unpick the Gordian knot of finance, which is this time, but I've got certain things I'd like to ask about finance and cyber security. And there's one little item about the Darwin Centre, if possible, please. Can I start with cyber security report, please? That was rather a high-level report, but obviously there are public-facing stuff within digitalisation. You know, the NHS app, EPR, etc., etc. How are you getting through to the general public that they can trust the safety and security of such NHS app, EPR, etc., etc., and anything they may use? Because what we're talking about is very sensitive data that may be available to individuals, but in the hands of certain elements can be very useful for scamming, etc.
Thanks for the question, Ian. Chris?
So, Ian, thank you very much for that question. So what we are doing, certainly, it's not technical, but we are working with libraries to improve the training and the guidance for people to not only register for the NHS app, but also how to use it effectively to access different forms of information that are being released as development of NHS app takes place. The second thing I would say is, from a technical perspective, it's very important that access to our systems is strongly managed and controlled. And a lot of our systems, as you will be aware, are now, we require multi-factor authentication to access applications. So, I think it's a combination of education and support of our residents, as well as improving our technical, the technical aspects of the solution as well. But needless to say, I mean, the NHS app team, focus on making sure that that information is held securely, and that individuals that access it and or carers on their behalf, can access that in a secure fashion. I'm very happy, as always, Ian, to go into further detail as required and follow separately with you on that, if you would wish to do so.
Thank you very much for the offer. I'll probably be taking that up at a future date. Thank you very much for that.
Sure.
With the Darwin Centre, it's first I've seen of this level 3 oversight. I mean, I saw that Nussas Combined Healthcare had mentioned in one of their reports to their board that quite a high usage of agency nurses at the Darwin Centre, etc. But who actually manages the Darwin Centre? I don't believe it is you, is it? I believe it's NHS England. And will there be a change? Because it's a specialised regional centre, as I understand, of CAMHS. Is that likely to change with the specialised commissioning that becomes apparent next fiscal year, 24-25?
Okay, so is anybody, Bucky, do you want to come in and just make a comment on Ian's question? Thank you.
Yes, thank you, Chair. So the question about who manages is us, as in Nussas Combined, but you are right that it's a regional centre and therefore commissioned by the West Midlands Provider Collaborative. So that's the direct answer to the first question, but there was, I don't know whether you wanted to ask further questions about it.
Yeah, right. West Midlands Collaborative, is that an NHS England thing?
Yes, so that's the specialised commissioning. That used to be specialised commissioning.
Yes.
And that's been devolved to the Provider Collaborative that's led by Birmingham Women's and Children.
Right, and is that likely to change with the specialised commissioning per se is subtly changing over the next few years? It's changing definitely next year. Is that going to change for that particular regional CAMHS centre, or will it remain within the remit of the West Midlands Collaborative?
Yes, yes.
Okay, thank you very much for that. Thank you, Bucky.
Right. Thanks, Bucky. Ian?
Right, and finance. I attended UHLM board January, and they're reporting £23 million deficit by year end. You've got to get rid of the 56 million over above the 90 million that's already been covered within the next 3 months, according to NHS England. How on earth can you do that? I'm an outsider looking in. How on earth can you do that without shutting down the services completely? That seems to be an impossible task. And what are the consequences if you don't get rid of that £56 million variance at this moment in time?
Thanks, Ian. Paul, do you want to pick that up? And Peter may have comments as well.
Yeah. So your numbers are right, Ian. That's spot on. So the 23 deficit that so it's the same issue. It's what we're calling unmitigated risk. So that is the number that UHM is citing, 23. That 23 is part of the 56 that I mentioned. Yeah. So essentially the 56 is made up of 2 parts, the ICB and then UHM. That gets us to 56. So that's the technical answer to that bit of it. In terms of can we get back to break even, I suppose it goes back to the conversation that we had in the meeting and the question that Julie posed. So at this moment, we've been the ask of us is very, very clear. The ask is that we break even, and that's what we've been told to do. We have not got a pathway to that yet. That is true, and we're running out of time, which I think is part of your question. That all those things are true. We are making progress, as you saw on the numbers that I showed, that we are making progress towards that. Whether we kind of run out of time and it's impossible to get there by the end of the year, that I'm afraid is quite possible. We expect to see some improvements in that position in month 9. I'm then hopeful there'll be further improvements in month 10. By month 10, we will then be in a position where I think it's pretty much kind of certain where we're going to get to, because by then we'll know what costs we have, and it's going to be impossible to put any further costs out. So we are having conversations with the regulators about that. If by the time we get to month 10 we're still in this position we are now, which is that we have no pathway to break even, then we're going to have to have that. We're going to have that frank conversation with NHSE about that at that point in time. I don't know what will happen, but that's a conversation we'll have. And as Julie said, I think at that point we might require a special board meeting to decide our response. So that's kind of where we are, Ian, in terms of that. We're getting close to knowing. We don't quite know yet. In terms of the impact, well, there are penalties of missing, certainly financial penalties in terms of missing. There's a loss of capital, and we badly need capital, so we're very keen, obviously, to get there to maintain capital allocations into the new year. And there are also effectively levies charged in next year's money if we fail this year. So again, we want to avoid that. Next year's hard enough as it is. We want to get there if we can. But as I said, if we can't, and you're right, it might be impossible. And if it isn't possible, then we'd have to be open and straight with the regulators about that and have that conversation.
Yeah, thanks, Paul. Ian, thank you very much for.
Can I quickly come back on that, please? Can I quickly come back on that?
You can, Ian. Yeah, quickly.
You've not exactly been profligate. We understand that there are efficiencies, but the system hasn't exactly been profligate. It's faced massive surges in demand, especially in urgent and emergency care. So how is that getting through to NHS England? Just seems to be on a different plane. Is that getting through to NHS England? I would hope it would be.
Yeah. So, Paul, if you want to pick that up, and then Peter, I certainly have a view on that.
Yeah. Well, I'll put out an overview to you guys. Yes, of course they understand that, and they understand the relationship between the high volumes and the demands on the service and the money. They absolutely do. There is only so much money in the NHS coffers. That's the point. And Julian Kelly and his team are stating to us that that's all the money that there is, and we must live within it. And we understand that. It's obviously easier said than done, isn't it? As you're saying, it's about how do we balance those things off. And so they're not blind to that point at all, Ian. No, not at all. But they are asking us to break even, which they have to do because they only have so much money to give us.
Okay.
Peter, do you want to just make a final point on that?
Yeah, just very briefly. Afternoon, Ian. So what I'd add is probably 2 points. One, the Darcy report, people may have forgotten about that now, although it only came out a couple of months ago. I thought was a really helpful summary of the challenges that we face at a broader level across the NHS. Of course, it wasn't just Staffordshire, but I think it's important that we remember those challenges that were described: significant reductions in management capacity to enable transformation, etc., etc. So, we're not immune to any, if not all of those items within the Darcy report as local level. So that's the first point. But then it does link to the second point, which is the centre do repeatedly mention to all systems the deterioration that they see in the data of the productivity levels of the NHS, right across the country. And again, we're not immune to that. Now, there's a link. I mentioned both of those together because there is a link between reduction in productivity, which has happened. The ONS data does indicate that. But all of the impacts that the Darcy report describes. So I think the reality is the challenge for me is about how quickly generally can turn the tanker effectively and bring back that productivity improvement and all of the things that are expected by the centre and are described in relation to the challenges by Lord Darcy. So I think there is opportunity there. I think the challenge for us all fundamentally is the speed of improvement that we can deliver. And I think that might be, for me, if I was to be really honest, Ian, the discrepancy perhaps on occasion between central expectation and local opportunity.
Yeah.
I hope that helps.
Thank you very much.
Ian, thank you for your questions.
Thank you, Chair.
Okay, colleagues, we'll move into item 17, if we can, meeting effectiveness. We started with our compact. Hopefully we've adhered to that. It certainly feels as though we have. Any comments greatly received if we haven't. If not, let's move into item 18 and close. The date and time of our next meeting is the 20th of February at 1 o'clock. And again, that will be held in public via Microsoft Teams on that occasion. So we conclude our business. Thank you to everyone who's contributed this afternoon and everybody who's joined us from the general public. Thank you, everybody.
Thank you, David. Thank you all.
Thank you. Bye-bye.
Thank you, David.
Thank you.
Thanks all. Bye.
Thank you.